I request Dr. G.S. Sinha, sir. Sir is Senior Physician and past President AMA. Dr. Kartike Sharma, sir. Sir is a Senior Neurosurgeon of repute. And Dr. Sujit Verma, sir. He is a Senior Physician and Professor of Medicine, MLN Medical College, Prayagraj. And Dr. Ashish Rai, Associate Professor, Neurology, MLN Medical College, Prayagraj. I now request the chairpersons to kindly introduce the speaker. Thank you.
And now, I welcome our next speaker, Dr. Abdul Qavi, Professor, Department of Neurology, Dr. RML Hospital, Lucknow. He will be speaking on the topic hyperkinetic movement disorders, and now I'll invite Dr. Qavi to deliver his lecture.
Thank you, sir, and good afternoon, everybody. I'm very thankful for AMA for inviting me and giving this opportunity. I'm presenting hyperkinetic movement disorders and role of botulinum toxin in these disorders. My name is Qavi, but I am not the poet, but I'll starting with this quote. This is a शेर लगभग ये शेर मिर्ज़ा गालिब के समकालीन लिखा गया और मैं इसको आज की इस CME को डेडिकेट करूँगा, ना कि अपने खाली टॉपिक के लिए बल्कि पूरी न्यूरोलॉजी CME के लिए, कि वो उम्र भर कहते रहे तुम्हारे अंदर दिमाग नहीं, वो उम्र भर कहते रहे तुम्हारे अंदर दिमाग नहीं, मूवमेंट डिसऑर्डर क्या हुआ, या कहें स्ट्रोक क्या हुआ, या यूँ कहें कि न्यूरोलॉजिकल डिसऑर्डर क्या हुए, ये दाग भी धुल गया. Now I will start with my topic. Movement disorders. What are the movement disorders? The disorders which are produced because of movement which are not normal. So whenever any person which is normal, having normal activity, can able to walk normally without any excessive or reduced movements, walks with a normal step, able to walk without any unsteadiness, with a normal stance, the weight, and he's able to turn normally, along with some associated movements like the movements of the hands we can perceive there, and these are the normal. So what abnormality can occur? There may be difficulty or abnormality in the speed, fluency, and the quality. So the movements may be decreased or increased without any weakness or spasticity. So we call them the movement disorder. There are two types, hyperkinetic and hypokinetic. Hypokinetic movement disorder or Parkinson's disorder will be discussed later. I will focusing on hyperkinetic movement disorders. So there is a long list of hyperkinetic movement disorders I will discussing, because these are disorders diagnosed clinically, and we use the term phenomenology, means the clinical description, the characterization of that movements. So we can identify or diagnose by seeing the patient in front. So I am discussing more on the videos rather than the theoretical part. So the most common movement disorder is tremors. The tremors very common, and when they becomes of moderate amplitude, the patient comes to us or consult to physicians. The tremors are rhythmical, involuntary oscillatory movements of a body part produced by either synchronous or alternating movements of contraction of the antagonic muscles. There are two types, rest or action. The rest tremor is feature of Parkinson's disease, and the action may be in the postural or kinetic form. The first cases of these tremors were explained by James Parkinson. He was a scientist, a physician, and a political activist who, in his clinic as well as in the streets of London, find some patients having abnormality in the form of shaking of the limbs. He wrote them as shaking palsy, and later the disease was known as Parkinson's disease. So the patients have tremors, that is the rest tremor, postural tremor of frequency 4 to 7 Hertz. So we commonly see these patients along with essential tremors. So the most common one is rest tremors. Rest tremors are present in the rest usually start asymmetrically. The pin rolling character, flexion, adduction, extension, flexion in the distally, when the limb is supported. So we can observe this gentleman having this rest tremor. In the second video, we can see the same type of the movements in the lower limb. When we ask the patient to do the tapping of the fingers by the left upper hand, we are able to appreciate that there is reduced amplitude and velocity, that is bradykinesia, along with the tremors in the left lower limb. So this is case of Parkinson's disease with rest tremors. Then another tremor we can find in Parkinson's disease, postural tremor, which is observed when patient is having hands in front of the chest in a particular posture. Like in this video, we can see the patient is having the abnormal movements on a particular posture. This is the postural tremor. Same thing we can also observe in the second video in the left upper limb. When the heads are in front of the chest, we can observe that abnormal movement. This is the postural tremor having frequency more than rest tremors, very close to essential tremors. Then another tremor is re-emergent tremor. It is very important for Parkinson's disease. When patient make a particular posture, initially there is no tremor, but after a latency of few seconds, patients start developing tremors. So here there is no tremor initially, but after a few seconds, patients start developing tremors in the right upper limb, then take another posture and started tremors in the left upper limb. In the second video, we can observe the same thing. Initially, there is no tremors. When patients hold the hands above, initially there is no tremor, and after a latency of few seconds, it starts developing tremors in the right upper limb. So the frequency of these tremors is close to rest tremors. The importance of these all three tremors is to make the diagnosis of Parkinson's disease, which is very effectively controlled by levodopa. Another tremor is essential tremor, and it is the most common tremor, or most common hyperkinetic movement disorder. Patients come to us with a positive family history, improves temporarily with alcohol, and have gradual progression. Initially, it is only essential tremor. Sometime later, develop into PD complex as well. So there are difference between Parkinson's tremor and essential tremor, but even then, in 20% of cases, it is very difficult to differentiate whether it is a Parkinsonian or essential tremors. Because in Parkinson's disease itself, there are certain variants. There is tremor predominant Parkinson's disease, where tremors are more common than rigidity and bradykinesia. This gentleman is having tremors in left upper limb. The tremors were present on the posture as well as in the rest. There is asymmetry. Left tremors are more common. We are giving higher doses of levodopa, but the tremors are not controlled. Tremors of the Parkinson's disease are not well controlled on levodopa. The effect of levodopa is better on the rigidity and bradykinesia, but tremors are not so good responsive. So many times we go for DBS surgery or the other options. That is botulinum toxin we can go for. Here we can see this patient is having left upper limb tremors. In the next video, we can observe this gentleman having tremors in both upper limb along with tremors of the head. The head tremors is very characteristic of essential tremor. In the postural position, we can observe these tremors are there. Many times these are not good responsive to primidone or propanol we are giving. So to reduce this amplitude, we can treat them as an intermediate therapy in the form of botulinum toxin. Otherwise, surgical options are available for that. Then this lady is a teacher, having difficulty especially in the writing because of these essential tremors on the posture. Patient is having some tremors, and these tremors increases while she is doing particular type of the job. Especially, we can see during activity, patient is having kinetic tremors. In the second video, we can see the patient after botulinum toxin. The frequency is the same, but the amplitude is very much reduced. We are injecting in this lady with flexors and extensors in the forearm muscles for the botulinum toxin injection. Now she is able to write better than earlier after botulinum toxin injection. This patient is having long-standing essential tremors. Later developed some Parkinsonian feature, some asymmetry in the movement. And while asking to write, he is having difficulty in the writing. And in the left hand, he is having very much tremors, very disabling tremors. Sometimes these tremors are present only on particular activity, like this gentleman is having difficulty, especially during drinking water or holding the object with the right hand. Initially, we can observe that there is no more tremor in the postural position, but on holding this object, we can start developing tremors. So these are the essential tremors. There are certain maneuver we do to differentiate between these different types of the tremors. The spirals we form to differentiate them. The writing is small size in Parkinson's disease, and in essential tremor, there is very much tremulous. And now with artificial intelligence, there are certain algorithms are developed to differentiate between all these types of the tremors. This is a treatment, pharmacological, surgical, and in between we can use botulinum toxin. So toxin is effective in Parkinson's disease when tremors are very high frequency, or in essential tremors and other tremors when the drugs are not so good, or not so good functioning in controlling the tremors. So in that cases, the different techniques are available by which, or by USG guided or EMG guided, we can use the Botox injection to control these tremors. So botulinum toxin is actually the most potent biological toxin produced by Clostridium difficile. It is used in neurology, in the movement disorder, especially in dystonia, spasticity, post-stroke or post-traumatic cases, in migraine, in hypersalivation, and in overactive bladder. These are the various indications for botulinum toxin. The mechanism is to block acetylcholine release at neuromuscular junction. It reduces muscle contraction. It produces only a temporary reduction in the activity of that muscle, chemodenervation, which is reversible. The effects occurs within 3 to 5 days. Peak effect is 2 weeks, and which lasts 3 months. So we usually inject every 3 months for these patients. The most common toxin is type A, which is most potent, clinically used. The preparations are onabotulinum toxin, that is Botox, epobotulinum toxin, Dysport, and incobotulinum toxin, that is the Omin. This is case of Wilson's disease. This patient come to us with dystonia and tremors in the right upper limb. The tremors, while holding the head against the chest, we can find that there is tremors are present, which is more or proximal, and these are like wing beating of a bird. We started with silamine and zinc. After 4 months of the treatment, the tremors very much reduced. Now another one is dystonia. This is third most common movement disorder, where there is sustained or intermittent muscle contraction, often resulting in twisting and repeated pattern movements, abnormal posturing, maybe idiopathic, genetic, acquired, and can be assessed or classified by axis 1, where there are clinical characteristics, and axis 2, where etiology is there. The types of dystonia are focal dystonia, like the blepharospasm, segmental dystonia, where the 2 adjacent body segments are involved, multifocal dystonia, where at least 2 non-contiguous parts are involved, and generalized dystonia, where trunk is also involved along with other parts. So we commonly see patients of cervical dystonia, which are idiopathic or sometimes drug-induced cases of who are on antipsychotics. The anticolis, this anti-adhesion, retrocolis extension, laterocolis or tilt, and torticolis, that is rotation or turn. These are the particular group of the muscle. After identifying which type of the dystonia is there, we inject botulinum toxin accordingly. So this first case is of retrocolis. This patient is having extension of the neck. We can observe them. In the lateral position, the head is extended. Along with dystonic tremors, patients having tremors along with that, and no overflow in the upper limb. And sometimes this patient takes some sensory tricks to control this dystonia. He uses the hands behind the head to control this dystonia. We treated this patient with botulinum toxin and trapezius. Then there is laterocolis, that is the tilt. The distance on this right side is reduced between the ear lobule to the shoulder. We injected here in the sternocleidomastoid, splenic cavities, levator scapulae on the same side. with a good response with botulinum toxin injection. This is torticollis patient having left turn along with left-sided dystonic tremors. In the torticollis, we have to inject same side splenius capitis along with opposite side sternocleidomastoid. So these dystonias having any involvement of single plane, many times multiple planes are also involved, like in this second video, patients having retrocollis along with left-sided turn. So these are the complex dystonia. And in these cases, EMG guided Botox injection is required to identify the correct muscle causing overactivity. This patient is having right tilt with dystonic tremors on the right side. We injected here on the same side of the splenius capitis on the right side sternocleidomastoid and levator scapulae. The elevation of shoulder is a compensatory mechanism. And after 3 months on the follow-up, we find that patients are quite good, having no dystonia. This person is having generalized dystonia, normal cognition, normal MRI, possibly DYT, having cranial, cervical, limb dystonia. Due to financial problems, we are only giving him botulinum toxin injections. This tongue is also involved. There is cranial dystonia along with. In this patient, there is segmental dystonia, that is cervical, left turn, along with truncal dystonia. So here paraspinal muscles are also injected along with cervical. This patient is having left upper limb dystonic posturing. Initially presented with only dystonia and jerkiness. Later, he developed some cognitive problems along with alien limb phenomena in left upper limb. This patient is corticobacillar ganglionic degeneration. This lady is having retrocollis with dystonic tremors. And this is sensory trick used by her to control these tremors. This person is having generalized dystonia, predominantly retrocollis and truncal dystonia. And when he takes his baby in his lap, this dystonia is reduced. Now we can see there is increased dystonia with dystonic tremors. And after botulinum toxin injection, patient is quite good. The retrocollis is controlled and dystonic tremors are also not there. Then another problem is writer's cramp. This is focal type of dystonia. It may be flexion type and extension type. In the first video, we can see this lady is having flexion type of dystonia. While writing, she is having flexion of the thumb and the fingers as well, with the wrist involvement is there, having difficulty in the writing. So here we are injecting in only the flexor compartment muscles. We always do this maneuver to write on the opposite limb to see any mirror movement, that is actually motor outflow. Here the thumb movements are there, flexion type, which shows motor outflow. The next video we can observe while writing, the patient start developing this extension of the index finger. So this is extensor type of dystonia. Here we have to inject only the extensor indicis muscle. Sometimes we observe the tremorlessness while writing. This is the writing tremors. So here we have to inject the flexors and the extensors of the forearm. There is so much difficulty in making a spiral because of these tremors. Sometimes we see the pronation. While writing, patients having excessive pronation and elevation of the hand, even at the level of shoulder as well. So we are injecting here the muscles of pronation, that is pointer teres and quadratus. Blepharospasm, that is increased blinking. This is another problem where there is excessive blinking, and sometimes patients become functionally blind because of that, and require sometimes opening of the eyes with the help of her fingers. Here we can see. So here we have to inject in the orbiculus oculi muscle, corrugator, and procerus because of the activity of that muscle. Same thing we can see in the second video. And these patients many times use sensory tricks to open the eyes. And there is a good response to botulinum toxin in these patients. Another is apraxia of eyelid opening. In these cases, there is difficulty in initiating the eye opening. It is sort of a dystonia, which is seen in progressive supranuclear palsy. This lady is having the same type of the apraxia. And by rubbing the forehead like this, patient improves and eyes open up. We are injecting, especially in the upper lip, because LPS is involved in these cases. The Meek syndrome is a segmental dystonia where there is a blepharospasm along with abnormal jaw movements. There is jaw opening type of the dystonia. In the case of jaw opening dystonia, we inject little pterygoid muscle and anterior berlia of digastric along with the ocular muscles. This lady is having Meek syndrome where blepharospasm is there along with oromandibular dystonia, lingual dystonia. Patient having jaw side-by-side movement along with jaw opening. We can observe the lingual movements, the movement of the tongue inside. So we have to inject genioglossus muscle as well. And she is showing her neck that there is dystonia or spasm of the platysma muscle. So here we are also injecting the platysma. Then hemifacial spasm in the area of seventh nerve distribution, there is twitching can be seen, which may be clonic type. Here we have to inject the muscles, the orbicular oculi. The horizontal movement is there of this angle of mouth, so we have to inject risorius muscle, mentalis muscle. Sometimes these movements are tonic type, in which there is tonic deviation or facial deviation. This is tonic type of the hemifacial spasm. So same territory we have to inject. Another one is hemimasticatory spasm. So it is not so common but can be seen where there is undulating type of the movements can be observed in the area of the fifth nerve distribution, that is masseter and the temporalis muscle. So here we have to inject these muscles, the masseter and the temporalis. This girl was having dystonia. Various medications were used but could not get relief. Presented to us status dystonicus. Because of financial issues, we can't able to do the DBS. So pallidotomy, that is lesional surgery, was applied. It is by the radio frequency. And she was quite good after the surgery. The facial movements are improved, the limb movements, the dystonia of the limb was also improved. But not completely, but better than the earlier. Now the chorea, this is another type of the abnormal movement where the movements are abrupt, rapid and jerky, brief, unsustained, irregular. Various areas of the body are involved with this chorea. Here we can see this lady having chorea. dancing movement of the body, the movements of the fingers. The other video is of Huntington disease, genetic test positive, is positive family history. We can observe the tongue movements, lizard tongue, motor impersistence. This child is having chorea along with dystonia, normal cognition, normal development. And this lady is having generalized chorea. Here we have used tetrabenazine, especially the pharmacological agents. Many times we observe patients with levosulfide develops orolingual dyskinesias, which are very troublesome and require botulinum toxin injection. And many times here the lingual dyskinesia is present. Same we can see in this gentleman, oromandibular dyskinesias and lingual dyskinesia after intake of etopride. Now, the levodopa which is used for control of the Parkinsonian symptom many times develops dyskinesia after years, 5 years or more, especially in the young onset Parkinson's disease. So it is double-edged sword. We have to use this cautiously. And after severe dyskinesia, patients are having better control with deviate surgery. Another video is of the lady is having lingual dyskinesia while talking. She was on antipsychotics, risperidone. So in this case, we have to inject the genioglossus muscle with botulinum toxin injection and change of antipsychotic medication. This patient is having choreous drag movement, drug-induced. The abnormal slow writhing movements of the fingers along with facial movements. Hemiballismus, this high amplitude movements can be seen in diabetic steatopathy, asymmetrical, or sometimes in stroke, hyperglycemic coma. Myoclonus of jerky shock-like movement, we can observe them in SSP, which is not so common in other areas, but in North India is common. I have taken this video especially to show the eye movements, the character of slow myoclonus, which is observed in SSP. We can observe them the same feature in the ocular movements as well. There is asymmetrical myoclonus slow. In the second video, we observe she is a case of CJD, having generalized myoclonus, and 14-3-3 protein is positive. There is cognitive decline, rapidly progressive dementia. The tics are the disorder we seen in especially in children, the motor tics or the phonic tics, voluntary suppressible, but sometimes patients having premonitory urge to do that. We can many times observe in the children this jerking type of the head movement, of the limb movement, or the truncal movements. She is having tics. She can suppress it voluntarily. In the next video, we can observe the head nodding and jerking movement. When this is associated with ADHD, we can use clonidine, otherwise tetrabenazine can be used. When these disorders are associated with some positive family history or associated OCD, ADHD, these are Tourette syndrome. This girl is having Tourette syndrome, having phonic tics, grunting type of the sound, along with abnormal jerky movements in the right hand. Her elder brother was also having the same symptoms. He improved, but she is having very difficult time with her. Many drugs we have tried. Now she is on clozapine with some results. The another is functional movement disorder. It is not uncommon to see these patients in the OPD, and most common one is the tremors. So here we find there is variability in examination. Morphology is, or semiology is different, and entrainment is present. In the both cases, we can see the movements are in multivectorial, and while doing the activity with the opposite limb, the movements are reduced or changed with frequency. This is entrainment. So we have to distract this patient. This was very challenging. This young girl presented to us after COVID period, and after some event, she's having difficulty on standing on the ground. It's very difficult to define in any type of the movement disorder. We started the cognitive behavioral therapy, cycling and physiotherapy, and we find that it was actually the psychogenic or the functional movement disorder. This was a very good case presented to us with 3 days history of fever, seizures, along with obsoculus and myoclonus. The ocular movements, which are multivectorial, present here, along with jerky movements of the upper limb myoclonus and ataxia. The scrub typhus was found to be positive. We treated with doxycycline, ceftriaxone, and steroid, and after 14 days of follow-up, she improved with subtle chorea. The subtle ataxia was there only, and this case was published in Green Neurology Journal. This is case of autoimmune type of obsoculus myoclonus syndrome, where the eye movements were present there in the form of obsoculus. Myoclonus was there, jerky, and ataxia. We started, the patient was found to be positive with GAD65. He is in follow-up since last 3 years. We treated with IVIG, methylprednisolone at that time, and rituximab. He is on maintenance therapy of rituximab. Now he is able, and there is no obsoculus myoclonus present there. These are the peripheral nerve hyperexcitability disorders where we can find their undulating type of the movements of the calf, and there is generalized type. Now I'm skipping this. This paroxysmal dyskinesia, very short duration, can occur after taking rest, and we can observe them. Treatment is sodium channel blockers like phenytoin and carbamazepine. So to study the phenomena of the disease without books is to sail an uncharted sea, while to study books without patient is not to go to sea at all, said by Sir William Osler. So it is very important to do and find out the semiology, phenomenology of the movement disorder. Thank you. Thank you very much.
Thank you, Doctor. Your pictorial presentation made the topic very easy. Otherwise, slide would have rotating over the mind, because people could understand what is myoclonic, what is trauma. Before going to the audience, I've got few queries.
Yes, sir.
Basically, I'm a neurosurgeon, although we have bound to see the neurology patient as well. My first question is that essential trauma is very common in common practice for the physicians or everyone. How many % of the patient land into the Parkinson's, frank Parkinson's, because we have followed the patient because I'm practicing for the long time. A patient who met me during their student life, finally once they reach to their max or some other hospital, they come with the Syndopa or some Parkinson's treatment. So at what point, that is first question is, what point we should transfer the patient on the Parkinson's treatment? If it is, second is the how much percentage of the patients land into the Parkinson's, because it's not clear to my mind.
So essential tremor is present very in a young age, we can find with positive family history. And what percentage is, I'm not very much clear of the percentage, but very less number of the patients go into ET-PD complex. Actually, it is an evolving and very a topic of very much discussion, where it is actually the ET which converts into the PD, or PD is separate entity which occurs with the age. It starts like other PD patients starts. So when there is change in the character of the essential tremors, like when this patient starts showing asymmetry, patients having slowness in activity, rest tremors. These features we find, which are the characteristic feature of the Parkinson's disease, then we say that it may convert from the ET to PD or isolated developed PD. And for that confirmation, we have TODAT scan, that is the DOPA scan, to confirm patient has developed PD or not, if there is any confusion. If we have features of bradykinesia and rigidity, then of course we have to start with levodopa. In that case, the pyrimidone and the other drugs will not be helpful.
What are the muscles you select for the tremors to inject the Botox?
Excuse me, sir?
What are the muscles you select for the injection in the tremors for the Botox?
In the tremors, sir. Primarily we see what is the site of the tremors. Most commonly we observe at the wrist level. So in that case, we have to inject in the extensor carpi radialis, extensor carpi ulnaris, and the flexor compartment, flexor carpi ulnaris and radialis. If the movements are at the elbow joint, then we have to inject the bicep as well.
Third, I'm sorry, I'm extending this. What is the exact role of the Botox in the Parkinson's?
Botox is usually we can use as an intermediate agent, especially in tremor predominant PD. The rigidity, bradykinesia, good response to levodopa. That if tremors are very high, they may have not so good response with the levodopa. In that cases, we can go if patient is not going for surgery like DBS, FRGUS. So in that case, for a bridging therapy, we can use to reduce only the amplitude of that movement. So disabling tremors can be reduced. Otherwise, we cannot control fully that tremors. Frequency cannot be reduced.
Role is less common.
Less common. But disability we can reduce definitely.
Being the chairperson standing on the dais, I'm forcing myself to ask a very silly question. It haunts my mind. Movement disorders can be classified into two in my mind. One is the supratentorial and another is the infratentorial. In infratentorial, you get ataxia, and all the movement disorders you always involve in the supratentorial area. Is it clear? Because I was just reading and thus it came to my mind, because many of the surgeons like Dr.Abdul, if you know, he has made the theory of the Gardner's theory, he has failed and he has made the new theory. So I'm just thinking if some neurologists can come forward and work so that. And I hand over my mic to my respected president.
Thank you, Doctor, for your excellent presentation. We have learned so many things. Because of pictorial depiction, it was very clear. Thank you once again.
Thank you, sir. My question is, what is your personal experience regarding response of Botox in congenital cervical dystonia or dynamic lower limb dystonia?
So in the case of cervical dystonia, we usually inject, if it is congenital one, they respond. Complex one cases, we have to inject with the help of the EMG guided machine. And many times we get response, but it is not always optimal in congenital when it is severe type. Lower limb we usually doesn't injecting at present because it requires higher doses, and the response is also not good at our center.
Thank you, sir. Question from audience.
This was a very excellent lecture. You have got a very, very good collection of the patients.
Thank you, sir.
I'm an ophthalmologist.
Yes.
I'm basically interested in essential blepharospasm. I keep on injecting Botox in these patients. Just during the discussion, I was thinking, is there any chance that the essential blepharospasm is part of Parkinson's disease, or essential blepharospasm may progress to Parkinson's, number one? And in cases of essential blepharospasm, after how many days you inject Botox, and what are the monetary aspects? How do you handle these injections, because they are very costly?
Sir, in the blepharospasm, we inject this botulinum toxin. We have in the institute at HRF, so the cost is not much there, only 90 rupees per unit. So in a session of blepharospasm, usually 2,000, 3,000, and every 3 months we have to repeat them. So overall yearly cost is not much, and there is no pharmacological treatment given in between there. So only on Botox. We continue there.
Blepharospasm is the peripheral disorder, and Parkinson's is the central disorder.
So the next topic is Parkinsonism. Please keep your questions. We have more to discuss on movement disorders ahead. Thank you, sir. Thank you, chairpersons and the speaker.
Thank you so much, sir, for a very wonderful presentation. I now request Dr. Ashok Mishra, sir, Dr. Ashutosh Gupta, sir, Dr. Anubha Srivastav, ma'am, to kindly come on the stage and felicitate the speaker and the chairpersons. Thank you.